So I'm Daniella Kadian-Dodov. I'm a vascular medicine internist. We run the non-invasive vascular diagnostic laboratory here, and I'm going to be talking about non-invasive testing for the diagnosis of PAD. I have no disclosures. So I have two objectives for you through this talk. Number one, I'm hoping after this you'll be able to choose the right test to evaluate patients with suspected or known PAD. And second, that you'll consider clinical parameters that may influence your testing in terms of what you choose in the workup of PAD. And so just to start as a quick overview, PAD is on the rise. It affects over 200 million people worldwide, and in the US, adults over 55 years, it's about 16% of the population. And it's important because these patients, regardless of symptoms, have a threefold increase in cardiovascular events, heart attack and stroke. And when we think about how these patients present, only the minority will come with clear symptoms of PAD. So 1 to 2% will present with critical limb ischemia, rest pain, or ulcers. 30% will have typical claudication that's relieved by rest, and the rest are asymptomatic or have atypical leg pain that's hard to tease out. And there are some key questions that you can ask to help sort out that leg pain. I'm not going to go into this in too much detail, but specifically intermittent claudication, you want to look for it to be reproducible if it's typical and resolve with rest. I would say the biggest confounder is spinal stenosis or pseudoclaudication. That's not relieved by rest alone. The patient often has to sit down to relieve the pain or lean over something. And then if we think about the anatomy of disease, the location of pain the patient presents with is going to be one level below the obstruction. So on the right, it shows you the frequency of involvement. And obviously, patients can have more than one level of disease, so those numbers don't add up to 100%. And on the left-hand side, it shows you the typical symptoms that patients may come in with based on their level of involvement. And I think the important things to take away from this slide is the more proximal the disease, if there is a need for intervention, the patient is usually going to do better. So as you go down the leg and get below the knee, that's usually where we start seeing obstruction due to diabetes, for example, or end-stage renal disease with calcification. And patency rates in that area below the knee is far worse than if you're looking at an aortoiliac lesion. And these are the many different phases of PAD. So you heard about some elevation pallor and dependent rubor in the last talk. You're familiar with how critical limb ischemia can look. Some other clues with atheroembolization, you may see the livido kind of pattern on the skin. And another ischemic ulcer over here, secondary to Berger's disease, which is not atherosclerotic PAD. But I just want you to keep in mind that it doesn't have to necessarily be cholesterol plaque causing the blockage. So if you're seeing a younger patient who has an ischemic ulcer, you still need to be thinking about the fact that there's an obstruction to blood flow somewhere, even if they don't fit the typical pattern. And then there's also a lot of overlap between venous and arterial disease. So up to 26% of patients with a leg ulcer will actually have both PAD and venous disease. There's some differentiations between venous ulcers and arterial ulcers that you may be familiar with. Venous ulcers tend to be wet with good granulation tissue, whereas arterial ulcers are dry, may have an eschar, and are very painful. And then where the ulcers actually occur can differ between the two. But it's important because the presence of PAD may limit your ability to adequately treat venous disease. So there is a threshold at which you shouldn't be putting your patients into compression. And that is if the ankle pressure is less than 60 millimeters of mercury or the ABI is less than 0.5. You don't want to compress those patients because you'll make things worse. So how do we actually evaluate PAD? I think about it in two ways. There's physiologic testing that tells us, is there an arterial flow problem? And we'll have some examples of that in the future slides. And then there's imaging, and that allows us to identify the lesion anatomically. So I have a question for you for this case. This is a 32-year-old gentleman who has no cardiovascular risk factors or significant past medical history, but has been having 2-block bilateral calf and foot pain with exercise that's getting worse over the last 2 years. He's seen a bunch of different providers, neurology, primary care, orthopedic surgery with no etiology identified. So if you were going to order an exam on this guy, would you go for physiologic testing or imaging? Perfect. I'm talking to the right crowd. Good. So yeah, Arterial Duplex combines grayscale and Doppler, so that allows us to actually visualize vessel morphology and plaque morphology, and then Doppler allows us to evaluate for blood flow velocity so we can actually find a stenosis or occlusion. So you can hopefully make out here a velocity shift at the level of turbulence in an area of cholesterol plaque consistent with stenosis. This does not tell you if this lesion is causing the patient's symptoms or if it's of hemodynamic significance. So this is not the test you want to get when you want to know if it's PAD is responsible or a blockage is responsible for the patient's symptoms. So physiologic testing with the ABI is what you want to get. As you heard in the last talk, this is the ratio of the ankle systolic pressure of each leg over the highest of the systolic pressure between the right or left. So if you're going to do in-office ABIs, you have to take the blood pressure in both arms. Because if they have a blockage in the subclavian artery, the systolic pressure in the brachial on that side is going to be low, and you'll get the false ABI if you do that. So this is the cornerstone of the PAD diagnosis. It consistently outperforms the pulse exam in any questionnaire for symptoms of typical claudication that we can give patients. And this is the same scale that was shown in the last lecture in terms of what's defined as abnormal, borderline, normal, or calcified. So in this patient, we have a brachial pressure of 160 versus 120 in the left arm. So which brachial pressure do we want to use for our ABI? 160, good. And then you want to take the higher of the feet. So you check both the PT and the DP when we do our ABIs, and we're going to take the higher of those two, and that's because it's the most specific for the diagnosis. So that would be on the right side 80 and on the left 120. So we have an ABI of 0.5 and 0.75, which are both abnormal. So this tells us there's a blockage somewhere between the arm and the ankle. What it does not tell us is where. So how can we get that information? We can get segmental pressures. I have some examples of that for you. Now, if you're getting repeat testing, there can be some variability sometimes, and people often ask, when is it significant? That threshold is 0.15. So if it's a difference of more than 0.15, it's significant between two studies. And what about for those patients with vessel calcification, your diabetic or end-stage renal disease patients, or those that have an ABI greater than 1.4? In those patients, you want to get the TBI, or toe brachial index, so we can actually take the pressure of the great toe and compare it to the brachial pressure. And then for those patients that are borderline or come back with normal resting ABI, we can do exercise testing to try to bring out the disease. And I have some examples of that for you too. So here's an example of segmental pressures. So we take both brachial pressures, and then in this example, we've got 3 leg pressures, the thigh, below knee, and ankle. And we pair that with a continuous wave Doppler analysis of the femoral artery to look for inflow disease. Because if the thigh pressure is low, we don't know if it's because there's common femoral disease or aortoiliac disease, and this continuous wave Doppler gives us that information. And basically, what you do is you take the ABI first in each limb. So if we were going to take the higher the brachial, 146 versus 127, we got an ABI of 0.87 on the right, 0.83 on the left, so both are abnormal. And then we look for our drop. And we're looking for a drop in the pressure of 20 to identify our level disease. So from 146 to 143, the drop is between the thigh and the knee. There is femoral popliteal disease on the right. And on the left, same thing, 137 to 117, bilateral femoral popliteal disease for this patient. And then these are pulse volume waveforms. The cuff's partially inflated, and you can actually measure the volume displacement of blood flow, and it mimics basically your arterial Doppler signal. And I have a slide with some examples of that as well. So here's a normal arterial pulse volume waveform. It should have a rapid upstroke, a nice dicrotic notch, and then go down. This is triphasic. If you have disease or calcification, the first thing you're going to lose is the dicrotic notch. Then you'll get a parvus tardus waveform, and then it'll be severely abnormal. So you want to look at both the waveforms and the pressures when you're looking at your patient's ABI testing. The important takeaway is if they're discordant, pressure trumps waveform. Waveform is subject more to artifact and technical differences. So okay, here's a different example. In this patient, we have an ABI on the right of 0.9, so just at the threshold of normal. On the left, 1.24 if we're taking the higher, so that one's normal. But in this case, TBIs were obtained, and they're abnormal. The threshold of normal for the TBI is 0.7. So you have abnormal TBIs and normal ABIs. Can anybody think of a situation where you might see that? Okay. So if you have a diabetic or a CKD patient with vessel calcification, you're going to potentially get a falsely normal ABI if the vessels are calcified, and the patient may actually have disease. So if you're seeing someone with those risk factors and you're suspicious that they have PAD, you want to think about ordering or asking for a TBI in addition to the ABI. And I'll say this again in the talk, but for your patients with CLI, 30% of them in the literature will actually have a normal ABI. So you want to make sure you're getting the TBI to assess for perfusion in that setting. So normal, again, for the TBI is 0.7. We use it most often when the ABI is greater than 1.4, or if we think the ABI is not reliable. So for example, you see a patient with a non-healing wound, but they have a normal ABI, you should get the TBI to be sure. There's some other parameters that I'm not going to go into in this talk to look for microvascular or microcirculation, the transcutaneous oxygen pressure and skin perfusion pressure that rarely some labs will offer. We actually don't offer that here, but they're subject to a lot of a variety in terms of variability in the results based on the patient's comorbidities. So, okay, back to this case with the bilateral calf and foot pain in that young gentleman that was getting worse over the last 2 years. He was sent for ABIs, and this is what came back. So if we were going to take the ABI in the right leg, 128 versus 161, we have an ABI of 1.26, and on the left, 1.18, so both normal at rest. So we exercised him. And the exercise protocol starts at a 12% grade, 2 miles per hour, and then it increases gradually with time. He actually was able to go pretty far. So he went 9 minutes, but at almost 4 minutes, he had the bilateral calf pain that stops him. And with repeat measurement of his ankle pressures, they reduced after exercise, and his ABIs went down into the abnormal range. Pretty unusual for a 32-year-old. So he ended up going for arterial duplex, and when we had the patient do plantar flexion at the level of the popliteal artery, the artery actually occluded and the waveform obliterated. And so this is popliteal artery entrapment syndrome. It's an anatomic variant where you can get entrapment at different levels, usually at the medial head of the gastrocnemius. And usually these patients require surgical intervention because of repeated arterial injury from that compression. They can actually stenose and then occlude. And so on angiography, when you have the patient plantar flex, this is what they would actually see. So for your typical PAD patients, when do you actually get imaging? Well, typically you're going to order it for those in whom you're thinking about an intervention, or you want to localize and characterize the disease. So your refractory claudican or patient with CLI, and all of them have pretty good sensitivity and specificity between duplex, MRA, CTA. There's some limitations to each one. Duplex ultrasonography is operator dependent, may not be as good for multi-level stenosis or heavy calcification. MR angiography you need to think about for your patients with renal disease may not be a good option. And with critical limb ischemia, because it's time-based, you might actually get dropout and not get the full picture there. And for CTA, you're exposing the patient to some contrast and radiation, and you're going to get blooming artifact with heavily calcified vessels. But bottom line, you don't want to send a patient for catheter-based angiography unless you really think they're going to be getting an intervention at the same time. It shouldn't be used these days for diagnosis alone, in most cases. Okay, this is one last case. So this is a 70-year-old with claudication. He has a lot of risk factors: MI, he had a kidney transplant, diabetic. He's got bruise on exam when we listen over his neck and his belly. And here's his ABI. So ABI at rest on the right, 0.9, left 1.24. This is the same case I was showing you before with the reduced TBI. He was exercised to make sure that the claudication he was reporting was actually responsible for his symptoms, and in fact, the ankle pressures did drop with exercise, 126 to 85, 174 to 119. I'm going to skip this, but he ended up having a bilateral common iliac artery stenosis that we picked up on duplex. So on duplex, what you're seeing here is a focal area of turbulence in the left common iliac artery. Here's the arterial waveform, which is monophasic, and the velocities are elevated. They were able to get a velocity shift at that level. He ended up going for angiography because, as I was saying at the beginning, patients with inflow disease have good patency over the long term. He also had this renal transplant coming off of the right iliac artery, which we were worried about. And in fact, he ended up having an infrarenal aortic stenosis, bilateral common iliac artery stenoses, and a right proximal external iliac artery stenosis. So he got bilateral common iliac artery stents, and post-intervention testing showed normal ABIs, both at rest and with exercise. And he had no symptoms during that. So after intervention, you want to repeat this testing to confirm that things have actually improved and have a baseline to follow your patients. So I think this is maybe my last slide. In summary, if you want to know if your patient has disease, both physiologic and imaging will tell you that there's PAD present. If you want to know where it's located, imaging is going to outperform your physiologic testing. If you want to know how it relates to the patient's presentation and symptoms, physiologic testing will tell you that, not the imaging. If you would like to know what your therapeutic options are, imaging will tell you better than physiologic testing. And finally, if you want to know the results of your therapy, that things have actually improved, physiologic testing alone will tell you that. Thank you.